So I think we'll get started. It's a great pleasure for me to extend a very warm welcome to you from OneWelbeck. It's great to be joining our primary care colleagues on this seminar where we're going to discuss colorectal cancer prevention, screening and treatment from the primary care perspective. And here are the panel that you can see in front of you. We've got 3 gastroenterologists, 2 surgeons, a radiologist and a GP. So hopefully a good representative group. I'm Brian Saunders. I'm going to start by giving you a little introduction to colorectal cancer. I'm then going to hand over to John Martin, who's going to tell us about screening modalities and the current situation in the UK with screening. He'll then hand over to Julian Teare, who's going to give us a more international perspective on screening. And then we'll get into some cases, discussing some real life cases, bringing in surgical colleagues, at radiology and from the primary care perspective. So let's get a start. So colorectal cancer is an important condition. Sadly, 42,000 cases per year in the UK, and that amounts to about a 5% lifetime risk, slightly higher in men than women, but the second most common cause after lung cancer of cancer-related death. And of course, the name of the game is early detection. If we get it early, we can nearly always cure it. And one of the few good things about colorectal cancer is that it starts as a benign polyp. So there is this opportunity to find the polyp, remove it, and actually prevent cancer. A little bit about polyps. They may be present for many years and really don't give much in the way of symptoms. So screening is the key. A lot of patients will have polyps. They're a common finding at routine colonoscopy. Not all of them will turn, but we kind of say to patients that perhaps 1 in 10 adenomas within their lifetime would turn into cancer if they weren't removed. The timescale for this is really unknown, and it's probably highly variable, but generally it's slow, 10 to 20 years. So there is this opportunity to remove polyps and prevent cancer. This is the sort of thing that we see very routinely at colonoscopy. It's a small adenoma, about 6 millimeters in size, and it can be very quickly and easily removed with a cold snare technique. We don't use diathermy. We just literally cheese wire the polyp off with a snare, retrieve it, send it off to the lab. And this simple process can help to prevent cancer. Polyps come in all shapes and sizes. That's a small one. Obviously, bigger polyps, such as this 2.5 centimeter lesion, requires some heat to remove it. And then there's a little bit more of a defect which is left in the bowel wall. And nowadays we tend to close these defects with endoscopic clips. It's a bit like putting a suture into the bowel wall just to reduce the risk of any complications such as bleeding or perforation. And these clips will stay there for a week or 2 and then fall off as the bowel wall heals. How does cancer develop? Well, the classic way that cancer develops is via the adenoma carcinoma sequence, which accounts for about 75% of all colorectal cancers. And this is a patient who came for a routine screening colonoscopy. The examination was completely normal until we got to the cecum. And then there was a quite obvious adenoma in the cecal pole. The modern colonoscopes have, in the CCD chip, in the video camera at the tip, you've got over 1 million pixels. You get incredibly detailed views of the surface. This is benign polyp that we're looking at here, where there's a regular crypt structure over the surface of the polyp. But as we come back and look in more detail at the polyp, you can see that there's a different area here with a small submucosal depression. And we can then interrogate this area using special light. And you can see that the crypt structures are completely destroyed in this area. This is a tiny 4 millimeter focus of invasive cancer. So having seen that, having spent time really carefully assessing the polyp, this is not one that we can remove endoscopically. This requires a formal oncological surgical resection with a right hemicolectomy. And just to make the point, as I come back, you touch the normal polyp, it doesn't bleed. You touch the area where there's cancer, where the cells are less well structured, and immediately you get a little bit of surface bleeding. So here we take a biopsy and refer on to Sarah or Oliver for surgical resection. So that's the adenoma carcinoma sequence, but there is a second sequence which has come to light really in the last 15 years, the serrated pathway. And these lesions are actually equally important to detect as adenomas are. And the serrated pathway accounts for about 25% of all colorectal cancer. There's a serrated polyp. Looked at in a little bit more detail, you can see this particular serrated polyp has a slightly different area here. And this is a tiny focus of dysplasia within the serrated polyp. And that's important because even though serrated polyps grow quite slowly, the way adenomas do, when they start to become dysplastic, the transition to cancer is quite rapid. So it's a really important finding. We want to make sure that we remove these polyps completely, as you can see here with endoscopic mucosal resection. So that's a little sort of introduction to polyps and cancer. But what about screening, which is really the key to making a difference to preventing this, this unpleasant disease? So John, I'm going to hand over to you. Tell us about screening modalities and the current situation in the UK.
Thank you very much, Brian. That's a great introduction. Thank you. So obviously there are a variety of different screening modalities that have been recommended by various organisations for screening, and they fundamentally fall into two categories. There are endoscopic procedures such as colonoscopy and flexible sigmoidoscopy, and then there are non-endoscopic investigations such as stool testing for either blood with either guaiac testing or fecal immunological testing, molecular testing within the stool, and then there's obviously radiological investigation of the colon with CT colonography. With that as a background, I just wanted to just run through the current NHS stance on bowel cancer screening, which is, I'm sure you're all aware, the bowel cancer screening programme. So this was initially started around 2006 and rolled out through the whole country by 2010. So initially this was guaiac testing, but a couple of years ago that was switched to FIT. But the principle is the same. You get, if you are registered with a GP aged between 60 to 74, every 2 years you will receive a FIT kit in the test, in the post, sorry, for which you are invited to put a sample of stool and return it, and that's then analysed by the hub. There are 5 hubs in the country which process these, and if they are above, the FIT level is above a certain value, you are invited to see a specialist nurse and then offered a colonoscopy for screening. The current result level is 120 micrograms, which, as you will see, is much higher than the FIT level which is used within the symptomatic service for the NICE guidelines for 2-week waits, etc. You'll be aware that until COVID, or from around 2011, there was a second modality of screening, which was flexible sigmoidoscopy, which is a one-off investigation to individuals aged 55. For various reasons, that has now been decommissioned, and from within the next few weeks, the fecal or the FIT testing program will be extended initially to 56-year-olds, and then every year another cohort, starting with then 58, then 54, down to 50. So within 4 years, the bowel cancer screening program within, this is England, by the way, in Scotland it is already at 50, but in England will be down to 50. And then within the next phase will be to decrease the FIT level down to 20. The rationale being that if screening program is broadened, then cancer will be detected early and prevented, and therefore the amount of colonoscopy this will generate will be offset by all the cancers, the lack of requirement to do symptomatic cases, because it will all be found with screening. This is population screening. So this is designed as a public health initiative to maximize benefit to the population. It this is FIT testing is obviously a very safe test. There is no risk to it. It isn't a particularly sensitive test, and as a result of population screening, because of the lack of sensitivity, there are individuals who will have a FIT test which is not sufficient to generate a colonoscopy, who may have certainly large polyps, and a significant proportion will have a cancer that will not be picked up by the initial screening test. So there is a role outside of the bowel cancer screening program for individual screening. So if, for example, someone comes in America now it's 45, but certainly around that age group, 45 to 50, they may be totally asymptomatic, and they may want to know, one, do they have a malignancy, or two, are they at risk of developing malignancy in the future? And this is a very different process. It is not about the population. This is a very much individual, single, one-to-one consultation. Do I have cancer? What is my risk? And in this situation, the same FIT testing are probably not appropriate. This person wants a definitive investigation with a high sensitivity. When I say harm is less important, what I mean to that is you are able to, because you can see the person if they're 50 and they're fit, the risk of a diagnostic colonoscopy is close to, in the right hands, is close to zero. So you can assess your patient, you can decide whether that's an appropriate test, and then these individuals can be offered a screening test, which we can discuss later. Is the most appropriate would be an endoscopic, highly sensitive test, such as a colonoscopy, to one, identify malignancy, which is unlikely, but more appropriately to identify polyps, which can then be removed and prevent cancer, and also risk stratify that patient for ongoing surveillance in the future. So that's what I've really got to say on screening. I'll be happy to discuss the different modalities, perhaps in the question and answer session.
That's great. Thanks very much, John. So just sort of to move quickly on, Julian now to give us an overview, UK compared to the rest of the world, what's happening with screening?
We're not doing very well is the bottom line. And so we'll see that the incidence of colon cancer has increased and increased significantly. And there are some sort of headline numbers that I think it's worthwhile keeping in mind. So 1 in 14 men in their lifetime will develop colon cancer, and 1 in 19 women. Now, the peak incidence is in mid-late 70s, but this is the window of opportunity to try to intervene to prevent this disease from developing. So how is the UK doing? Next slide. Now, if you see the previous slide, the incidence is increasing. This is a flat line. Now, with COVID, the CR UK hasn't produced much in the way of recent statistics, but actually, it's pretty simple to see this is more or less flat. There's not been significant change in the incidence of colorectal cancer over the last 20 years in the UK. Now, maybe that should be rising. This represents some benefit, and there's a lag. So the screening programs we put in place, we'd expect to see the reduction in colon cancer some 10, 15 years after they've been introduced. But these are little disappointing figures, and we'll come to some of the other figures across the world, see how they're comparing where they've introduced more individual screening programs. This is the US, so it's a very different looking line. The standard data from the Cancer.gov from the US. You can see it's about a 37% reduction in the incidence over the course of the last 20 years. So a huge change in incidence in the US. So we're way behind in terms of what we're doing. So how have they achieved this? Well, they introduced screening programs, and basically the parent company behind Welbeck has a huge database of procedures and looking over time. So although people say they want to start at 50, the average age at which people actually had their first colonoscopy in the US is 58. So the US has brought it forward to 45, and therefore hoping people would have it done in their early 50s. So they recommend starting screening at 45, colonoscopy every 10 years, seeking a colon every 5 years, or an annual stool test or visual examination, up to the age of 76, 85, based on preference, no screening after 85. Germany, again, figures to remember, 1 in 14 men, 1 in 90 women. Germany, 4.4 million procedures, 180,000 cases of colon cancer have been detected. So the figure the calculation is 1 case prevented for every 28 colonoscopies that were performed. It's a very dramatic figure to keep in mind. It's a very successful way of preventing bowel cancer. The US data from the HMO, the Kaiser Permanente, choose your endoscopist carefully so that the more diligent the endoscopist is, as are those at Welbeck, the more successful and the greater the reduction in subsequent risk of the disease. Every 1% increase in the adenoma detection rate, there's a subsequent 3% reduction in risk of colon cancer after the procedure, for the decade after the procedure. These are more than 10 years old, but they're published in 2014 in the New England Journal. So, these are really important factors to take into consideration for the individual screening program. So John's talked about population screening. Of course, what we cater for largely as endoscopists is much more the individual screening program. And these are in mind. What are the benefits of screening? Unlike some other screening modalities, colonoscopy is very, very successful and very effective. I'll drop back into the background. We'll answer questions later on. So I'm moving on to the cases now.
That's fantastic. So if anybody has a question, please put it in the chat, and there will be time to go through those at the end of the presentation. We thought to bring it to sort of real life, we thought it'd be interesting to look at some actual cases. So our first case, patient comes to see you. He's a 43-year-old male. He's worried about his risk of colorectal cancer, having just had the very traumatic experience of watching his sister die from colorectal cancer, aged 42 years. That's actually the only family history that he has of colorectal cancer. His parents are alive and well in the late 70s, early 80s. You ask him about symptoms, and he says his bowels are erratic, but they always have been. There's been no real change. He doesn't have any rectal bleeding or pain. And you do a general examination and there's nothing to find. Now, just a simple question, but one which I think is pertinent, is should you perform a digital rectal examination? So Shaima, I'm just going to bring you in there, and perhaps our surgical colleagues as well. There is this slight dilemma. Somebody doesn't specifically have anorectal symptoms, but it's pertinent to the presentation. Would you routinely do a digital rectal examination, or do you think it's a complete waste of time?
I think from a GP perspective, I feel that if there's definitely no rectal symptoms, and given the history and the case, and I would be anyway referring or for a colonoscopy, then I wouldn't be performing a rectal examination. But I'm not sure if that's the right answer.
I think I would agree totally with that. We went through our medical training being told we had to do rectal examinations, but actually they're quite unpleasant and quite invasive. And I think if you're going to refer on for a procedure anyway, then it becomes less relevant, and particularly if there aren't any symptoms. And is there a surgical perspective on that, Sarah or Ollie?
I don't think I would disagree with that at all. And even I don't always do a digital rectal examination. I saw somebody in clinic this afternoon at OneWelbeck where I knew immediately from the history that I wanted to perform a colonoscopy on that patient in the next 10 days. So I see no benefit in that person putting them through an intimate and invasive examination, because regardless of what I find, they're going to have that colonoscopy anyway. So I think only do a digital rectal examination if you think it's going to make a difference to your management plan and who or where you're referring the patient. The other thing I'd just say very briefly is that if you're not doing lots and lots of digital rectal examinations, then actually they're not always the easiest part of an examination to understand what you're feeling or seeing or so on. So if it's not something you do very regularly, I think it's of little benefit.
I would agree with that. I think in the absence of any anorectal symptoms, there's probably not much to be gained.
No. So John, the family history here, how pertinent do you think that is?
I think it's difficult, but I mean, I think most of the data on family history is that it probably, with a single affected relative, the risk is not as high as you would think it probably is. Having said that, I think I would certainly take that seriously and would do a colonoscopy on this patient. A lot of the BSG guidelines are actually slightly odd in this setting, I think. I mean, I don't know what you feel, but in terms of not taking single relatives too seriously, but actually, I would be concerned with that history.
And the sister was very young at 42, and I think you have to take that into consideration as well. So these are our options for what to do next. Would you reassure and discharge, routine bloods and fit test, CT colonography, flexible sigmoidoscopy, capsule colonoscopy, or colonoscopy? Julian, why wouldn't you do a capsule colonoscopy? Because I know you wouldn't, but why wouldn't you?
I think for two main reasons. It comes back to the 1% and 3% risk. So basically, I'm an endoscopist, so I think that what I do is the most appropriate test, clearly, but I also think that it gives the opportunity in someone who has a family history, not only of looking at what's the cause of their symptoms, taking biopsies to say, is there any low-grade colitis responsible for their symptoms, for their erratic bowel habit, but if you find polyps, you can remove them. So I think there is in a male, I would definitely hedge towards a colonoscopy and suggest the patient goes down that route. I think for women, I think there is more indication for the CT pneumocolon. I think again, in somebody, perhaps not this patient, someone who doesn't have a family history or at a young age and has vague symptoms that they've had for a long time, I think a CT pneumocolon gives you more information about the pelvis, about other organs. So in someone where there may be a lower risk of discovering pathology, you'll get more information from the CT pneumocolon. So I would push more women towards CT pneumocolon and more men, but in anyone who's got a family history or anyone who wants a screening test, then I go for colonoscopy because it offers the opportunity of discovering and removing polyps. And we'll find polyps in 40% of people who have a colonoscopy. So, 2 in 5 people who have a procedure will have polyps resected.
So Shaima, any benefit to doing some bloods and a fit test, which we could do in the primary care setting?
I don't think with that history, I mean, maybe bloods with the erratic bowel habit, but I don't think we'd get very much from that, but definitely not the fit test if I was referring him for a colonoscopy anyway.
Okay, so the patient went on to have a colonoscopy, and this is what was found. It was excellent bowel preparation, good use of the terminal ileum. Surprisingly, there was a rather large 20 millimeter minimally elevated cecal polyp, which is this very subtle lesion here, removed by endoscopic mucosal resection. And this was a sessile serrated polyp without dysplasia. And then there was also a second 5 millimeter tubular adenoma with low-grade dysplasia that was also removed. So, John, what would you do next in terms of follow-up? You've got a patient who's got both a large serrated polyp and an adenoma and a family history with a single first-degree relative under the age of 50.
Well, he's obviously at high risk of developing future lesions. So I think there are two issues. I mean, certainly in terms of his ongoing surveillance, he would need another colonoscopy probably in 3 years. The issue, of course, is whether we're happy that if that was taken in pieces, whether we're happy that has been totally resected, and whether you go back and just check that lesion has been resected. But it is because the trouble with sessile serrated lesions is often they look out, but there can be sometimes areas that extend beyond where you can actually visibly see. So we obviously take a wider margin for these, but it's probably in terms of his ongoing surveillance, I think 3 years, but there'd be an argument to go back and just check that there is no recurrence at that site.
Right. So keeping on colonoscopic surveillance. So this guy's going to have a number of colonoscopies in his lifetime. I think the important thing to remember about modern colonoscopy is it is civilized. And even though we look a bit scary with our PPE on, actually it should be a very civilized experience for the patient. We have a unique thing at OneWelbeck in that consultant anaesthetists are present at all of our colonoscopy lists. So patients can be given tailored sedation. And of course, all patients are different. Some want to be wide awake and want nothing at all. Some want to be asleep. And with that ability to give propofol by the anaesthetist, we can do that and really make sure that people have the experience that they want. As John alluded to, if colonoscopy is done well in experienced hands, it's extremely low risk. The main risk is from polypectomy, where there will always be a small risk of post-polypectomy bleeding in larger or more complicated polyps. But I mean, our figures to date with OneWelbeck are exceptional, with very, very low. Well, I don't think we've had any major complications at all, but Julian can update us on that. But it should be a very straightforward and low risk procedure.
No major complications. There's one question, Brian, that came through, which was, would that lesion have been detected on CT or capsule colonoscopy? And
shall we ask Stuart? Shall we ask Stuart that?
So in terms of the CT colonoscopy, we know that CT colonoscopy relies very much on the quality of the examination, as does colonoscopy. And a good quality examination, the patient's being compliant with the bowel preparation, then I would hope we would see that lesion. Yeah, we're increasingly recognizing the flat lesions. We can look at the CT images specifically for flat lesions as well as the more polypoid lesions. So I would hope that we would see that on a good quality CT.
I think they're difficult to see, and I think one of the things which draws your eye to it as an endoscopist is they have a mucus layer over the surface. So I think you would see that on that mucus layer, adherent mucus layer, would draw your eye to it both on endoscopy and probably on CT pneumocolon. I worry that with the capsule, that you don't have the ability to sort of stop and keep on looking and checking and flush and wash and see, you know, is there something beneath the mucus layer it flies past. I suspect those are the lesions that will be harder for that technology. And these are all, you know, any screening modality, that it's all good. It's all getting some sort of screening is all a benefit. It's just which is the best modality.
I'm sure Stuart would see it, but not every radiologist would see that lesion in the secant because it is very subtle and quite easy to miss endoscopy.
I would agree. And just, I mean, in a 42-year-old with the history where this is a purely screening examination and every lesion potentially matters, then I would agree with Julian that colonoscopy is probably the first line test here. And we can discuss where CTC comes in here a little bit later.
So this is a young patient. He's got his life ahead of him, and he's anxious about reducing his risk. He's been found to have some polyps. He comes back to see you in primary care, and he wants to know what he can do. He can't change his underlying genetics if there's a genetic predisposition, but what can he do to reduce his risk in the longer term? So Shaima, do you want to sort of talk us through this slide?
Yeah, thanks, Brian. So I think, as previously stated, the risk factor, one of the risk factors for colorectal cancer is, the increasing age. Most are detected over the age of 50, but and even though in the US there has been a decrease in colorectal cancer over the age of 50, there has actually been a 2% increase in the under 50 age group. So that should probably be borne in mind, particularly if they're of Afro-Caribbean race and African-American race, where it's been proven to have a 20% higher mortality than the rest of the population. And this is still not unclear whether this is due to biological reasons or due to decreased access to screening measures. I think the other thing we talked about was the family history, and in the case that we just saw, it was, there was just one a relative that was who had been affected by colorectal cancer, but obviously looking out for the common known genetic conditions that can increase the risk of colorectal cancer, such as familial adenomatous polyposis, FAP, which actually symptoms can appear around the age of 16 and has a 90% chance of having colorectal cancer in untreated individuals by the age of 45. And obviously there's Lynch syndrome, which everyone is aware of. And I think particularly important to remember that this is also associated with other cancers, endometrial cancer, specifically in women. And if there's a family history of that, that should also probably be taken note of. Smoking increases the risk of colorectal cancer, as does alcohol. A meta-analysis of 27 cohort studies, 34 case control studies, concluded that compared with never drinkers, there was a significant increase in colorectal cancer for moderate drinks per day. That was 2 to 3 drinks, compared to heavy drinkers, that would be greater than 4 drinks per day, but not light drinkers. And these results are consistent with other pooled analysis. However, in contrast to previous studies, a dose response analysis found a significant 7% increase in risk of colorectal cancer, even in light drinkers. So it's important to take that to note. The reason for this may be due to interference of folate absorption by alcohol, which I guess we can talk about later. Diabetes also has an increased risk of colorectal cancer, maybe due to insulin resistance, is thought to maybe be the reason for that, and they have a higher mortality rate as well. High red meat and diet, I mean, that I think has been talked about a lot, and actually specifically with the red meat, if it's actually cooked in a way where it's on a barbecue and pan fried, because that increases the carcinogenic effect of it, and processed meats as well. And so the red meat intake has been advised to not more than 500 milligrams twice a week is the advice, and obviously no processed meats whatsoever would be ideal. There's a lot of controversy around folic acid and vitamin D. I think particularly with folic acid, because there seems to be 2 schools of thought with this, from what I can actually reduces the risk of colorectal cancer, but some studies have actually shown that it increases the risk of colorectal cancer. It's suspected that probably the increased rate of colorectal cancer is with people who already had polyps, who hadn't had them removed, and it's actually increases basically enhances the growth of these polyps. And with vitamin D, the analysis, recent analysis have shown actually it does actually, decrease the risk of colorectal cancer, as in higher levels of vitamin D. So their meta-analysis of 17 pooled studies showed that vitamin D levels above 75 decrease the risk of colorectal cancer, and less than 30 nanomoles per litre actually increase the risk of colorectal cancer. And similarly with calcium, low levels of calcium have also been shown to affect the increased risk of colorectal cancer. So I think in answer to your question, Brian, the factors that we could change, which we can't change genetics, we can't change any age, unfortunately, but obviously dietary changes, high fibre, obviously I haven't talked about, and the WHO studies have shown just a 10-gram increase in your fibre, dietary fibre, decreases your risk of colorectal cancer substantially. So high fibre diets, low meat diets, reduction in alcohol, stopping smoking, obesity, obviously we know that has an increased risk with all cancers, and also with has an association with colorectal cancer as well. So and a sedentary lifestyle. So exercise will help with both the obesity and obviously the sedentary lifestyle as well, and weight reduction. Low dose aspirin, so you've got a question mark against that, and that seems to be still out there, but there's a lot of evidence to suggest that aspirin actually does reduce the risk of colorectal cancer. The difficulty is knowing the dose of that you should be taking to do that, and also obviously the risk of taking it long term, and whether it's going to cause any you've got increased risk of bleeds, etc. Saying that, I think the American Cancer Society have recommended it if the patients also have cardiovascular risk. Cardiovascular risk on its own increases the risk of colorectal cancer. So by taking aspirin, you would be obviously helping your cardiovascular health, but also reducing your colorectal cancer risk.
Aspirin is just a wonderful drug, isn't it? And it costs nothing, but only in low dose, and there is a side effect risk. So perhaps not for most patients. There is a good evidence base in Lynch syndrome for low dose aspirin, but routinely it's a double-edged sword. So let's move on. We've sorted our first case out. This is a second case. A 59-year-old businessman. He's got type 2 diabetes. He's been trying to lose weight and has done quite successfully over the last few months. He's got his BMI down to 26, but he's developed over the last 2 or 3 months a change in bowel habit. He's going more frequently, 4 times a day, and the stool is looser than normal. And he has had a single episode of rectal bleeding, which he described as darker red blood mixed in with the stool. You examine him and he's a little tender over the sigmoid colon. There's no mass to feel. You do a rectal examination and that is normal. So what next? Can I ask Sarah and Ollie, what do you think? What would you do next?
So, I mean, I think with this gentleman, I'd be inclined to go for a colonoscopy as a first line of investigation for him. He's got dark red rectal bleeding and a change in bowel habit and some abdominal symptoms. I think a FIT test would be potentially useful, but I think regardless of the result of it, he's probably still going to have a colonoscopy.
Okay, I think most of us would agree with that. Ollie, do you want to just talk about the trigger factors which make you worried about colorectal cancer?
Yeah, delighted to, Brian. I'd say that taking that last patient, he's a good example of the ones that really do ring alarm bells in a clinical setting. So any patient who is seeing dark blood, often mixed in with the stool, and who's had a very significant change in their bowel habit. And the key to a change in the bowel habit for me is the increase in frequency. And that can reflect one of two things. It's either a change in the actual consistency of the stool that they're passing, but often it's an obstructive effect. And what they're actually going to the toilet for repeatedly is tenesmus, and this feeling that they cannot get an adequate evacuation of their bowel habit. And that's actually often quite a late sign, and it's always, I think, quite a concerning sign. The other symptoms that you've got on the slide are all sort of valid and are all reasons why we would expect to see patients referred in for further tests and investigations. The things that really ring a red flag in my mind, particularly for left-sided lesions, are the things that we've just mentioned. The other thing I'd just say on symptoms before I pass it back to you is to just remember a few other things. Bowel Cancer UK did a survey that showed that 40% of the public still don't know what the symptoms of bowel cancer are. And that's despite huge public health initiatives and the fact that, as you say in your introduction, it's the second commonest killer in terms of cancer deaths in this country. And yet nearly half of the population don't know how to recognise it.
Yeah.
And that while symptoms are important, they often come on late. And so actually everything you've been addressing up to this point about trying to get in there before symptoms arise is actually of more importance in some ways, because by the time we're getting to tenesmus, significant change in bowel habit, abdominal discomfort that is persistent, weight loss, things like that, that's nearly always associated with really quite advanced disease. Of course, these symptoms often might be the sign of other important pathologies. That's the other thing I think we should remind ourselves of. It's not just a case of cancer or no cancer. It might be that you give them the good news that they don't have cancer, but you diagnose for the first time their ulcerative colitis. Or diverticulitis that's going to need a more active approach. And then the final thing I'll say before I pass it back is symptoms in the young. Sarah was reminding me before we came onto the webinar that the average under 50-year-old who is diagnosed with colorectal cancer has often sought 5 times on average assistance with symptoms before being referred on. And that's because they drown in a sea of hemorrhoids and fissures and pruritus ani and fissure in ano and poor diet and poor toilet habit. And so the primary care is horrific. I mean, my wife's a GP, and it is incredibly difficult to work out how you pick that out. And that's why we need a more robust screening program. And then the final slightly concerning statistic is that by the time of 2030, so in another 9 years' time, 1 in 5 rectal cancers will be being diagnosed in under 35-year-olds. So it's a disease increasingly of the young, and those young people are the same people who are going to come and see primary care with their hemorrhoids and their fissures. So symptoms are really difficult and really challenging, and I think we have to use tools like FIT and colonoscopy to try and help us triage these patients.
Just quickly, any ideas from the panel as to why we're seeing younger patients getting colorectal cancer? I mean, is this a lifestyle thing? Is this because we've got an increase in obesity? Is this because our diet is poor? Is it due to global warming? Is it in carcinogens?
I think there's no evidence for one single thing. The suggestion is that it's a multifactorial problem.
It's a real phenomenon.
Yeah, it definitely is. There's been a 45% increase in people with bowel cancer under 50 since 2004.
It's a worrying statistic. So the patient went on to have a colonoscopy and had this lesion at 14 centimeters from the dentate line. And there are some features of this which are concerning with, again, the central depression. But actually the crypt structures were reasonably intact. And the biopsies came back as showing high-grade dysplasia with no definite invasion. So, Stuart, let's bring you in here. We want some more information on this lesion. It's a worrying looking lesion. What tests should we be doing on this now?
So what we tend to do for the local stage, I mean, you're interested, has this lesion gone through the bowel wall? Has the biopsy missed the invasive component? And this is a tumour and it's gone through the bowel wall. So in the rectum, we use MRI scanning. We get a very good tissue contrast resolution, so we can see the muscle of the rectum. We can see the lesion separate from that, and we can give you an assessment whether it's into the muscle wall or particularly if it's through the wall. That would clearly influence your management. In terms of the metastatic status, we still use CT as our workhorse. It's a very sensitive test. It's a very rapid test. Radiation doses now are getting lower and lower, so we're not concerned about individuals having CT, particularly for a lesion like this. And if we have any doubts for in the liver, for example, we can do MRI scans of the liver as well. So our typical pathway would be a local MR staging scan and a CT for the rest of the abdomen.
And just to make the point that if we find this sort of thing at endoscopy, we can just send them literally a floor away and they have their scans done immediately if we need to do that. Yeah. Everything is very much teed up here for that. So the patient had an MRI and a CT and there was no metastatic disease, no abnormal lymphadenopathy. And because there was high-grade dysplasia and we didn't have a definite tissue diagnosis of cancer and there was no concern on the MRI of submucosal invasion, the patient went on to have what's called an endoscopic submucosal resection. This is an endoscopic technique whereby we remove the lesion en bloc by using an endoscopic knife and dissecting just just above the muscle layer to clearly create a big biopsy to remove the whole thing. But unfortunately, there was a tiny focus of cancer within this within this polyp. Very small, only 4 millimeters, 2 millimeters depth of invasion, but there was another high-risk feature, which was tumor budding. So, of course, this patient is relatively young at 59. We went on, I think we'd all agree in this setting, surgery is necessary. Let me bring in Sarah here. I mean, would you ever consider doing a further local excision of that scar? Because this will heal and become a scar. Is there any merit to that?
I think this is a conversation you have to have with the patient because there's two aspects to it. One is the luminal disease and the other is the mesenteric disease, even though we've had clearance on the MRI. And the patient's got a few adverse features. So invasion depth in itself is not a particularly adverse feature, but tumor budding is. We haven't said on the histology here whether they've got lymphovascular invasion, which is the most worrying feature for this, because what you want to be talking to the patient about is their risk of having any metastatic disease in their lymph nodes that's not detected on MRI.
There was no lymphovascular invasion. What would you say to the patient? This is a patient, he's 59, he's expecting to live to be 99. What are his risks of having lymph node involvement?
So his risk,
you don't know, but what would you give him as a
ballpark figure would be about 10 to 12% for this patient. Okay. And so it's really a conversation with the patient about whether he wants to take a 10% risk that he potentially could present with metastatic disease in the future, but the alternative being resectional surgery.
And Stuart, is there any way you can help with knowing whether the lymph node status?
So we know that we'll miss microscopic disease in lymph nodes, where we're still, most of our imaging is based on size criteria, and we know that's quite a blunt tool. We can reassure you when there's no lymph nodes there, as in this case, or very tiny ones that don't look involved. What we tend to do is follow the patient up. If the patient chooses to have a surveillance type approach and not go for resection, then we would do interval scanning and we'd be able to detect the growth in any lymph nodes, and that would flag that the patient may have disease. So wait and watch programs, which you may or may not discuss in terms of rectal cancer, post-chemo radiation, the MR follow-up's key to that, to look for the extraluminal disease.
So in this particular case, the patient had that conversation in outpatients. He didn't think that 10% was, he didn't want to take that risk, went on and had surgery. Sarah, do you want to tell us a little bit about modern bowel cancer surgery?
So here at OneWelbeck, we've got a team of 15 gastrointestinal surgeons, and between us, we perform upwards of 400 bowel cancer resections a year. Everybody performs minimally invasive or laparoscopic keyhole surgery, which is the gold standard, both in terms of oncological outcome, but in terms of, for the patient, smaller wounds, less pain, faster recovery, faster return to work, less incisional hernias. And we also have robotic expertise within the group. So we can cover every aspect of bowel cancer surgery, from local excision for early rectal cancers up to exenterative surgery. And I think it's important to say as well that surgery remains the main modality of treating cancer in terms of achieving cure. One of the exciting things that's happened in the last few years is local excision of early rectal cancers by minimally invasive surgery through effectively keyhole surgery through a port in the bottom. And what this enables us to do is take a slightly deeper layer than the endoscopic mucosal resection and go full thickness through the wall of the rectum, and normally we close this. You can see some pictures here. This is an obvious cancer with a depressed rectal lesion, albeit a fairly small one. We can take a full thickness excision of that with clear margins, give a nice specimen. They actually heal up very quickly. At 3 months, you can see that there's been complete healing of the mucosa there, and it gives you an en-bloc full thickness resection, which avoids sometimes the issue of having cancer, the resection margin with polyp excisions. So as I say, we can cover the entire range of it. If we go back a slide, the other things we offer a sort of full range of packages at OneWelbeck for people's cancer journey. And maybe you'd like to go through that.
Yeah, so I think it's important to emphasize that when a patient undergoes surgery for colorectal cancer, it comes with some sequelae. So even with modern techniques, the fact that most 85–90% of our resections are done laparoscopically, and Sarah and I would expect the majority of our patients to go home between about day 3 and day 5 after a bowel cancer resection. Often, particularly if the resection is done low in the pelvis, removing a lot of the rectum, you will get, as a result, further symptoms. You might get, for example, the presence of a temporary or even a permanent stoma. We have nurse expertise in stoma care management here. You may get symptoms as a result of your anastomosis and the loss of some of your rectum called low anterior resection syndrome. That happens in around 40 to 60% of patients who've had a rectal cancer operation. And what those patients benefit a great deal from is further biofeedback therapy, pelvic floor physiotherapy. We have a full-time pelvic floor physiotherapist based here. So providing that wraparound care is very important and is a key part of the offering that we have here at OneWelbeck. Finally, stuff that we are looking to get up and running is some of the more important stuff around colorectal PROMs, so patient-reported outcome measures, which we're going to be collecting digitally, and also hoping to put together a surveillance and survival package for patients, because one of the things that a lot of patients struggle with after diagnosis is then care in the subsequent 5-year period.
So this particular patient had a high laparoscopic anterior resection. There was actually no local recurrence. It was a T1 cancer, but had the reassurance of knowing that this cancer has been cured. Did get some symptoms at 6 months of bowel frequency, and that's where our biofeedback nursing team come in, and I think they provide a fantastic service for a range of different bowel disorders, not just for anterior resection syndrome, but for constipation, chronic constipation, and incontinence. And it's a real asset to have within the OneWelbeck armamentarium. I think we've probably got time for one more case, which is a very different type of case. This is a lady at the other end of the age spectrum. She's 87. She lives alone, but she's self-caring. She has good family support. She's got quite a lot of comorbidity with ischemic heart disease. She's got 2 coronary stents. She's got a reduced left ventricular ejection fraction. She's anticoagulated on rivaroxaban, has a permanent pacemaker for has atrial fibrillation. She recently had some sepsis following a hip replacement, but she did have a hip replacement, which has improved her mobility. And her EGFR runs at about 40. She's had a colonoscopy previously in 2010, where severe diverticulosis was noted. It was a technically difficult procedure, but no polyps were seen. But she comes to see you because on some routine blood, she's got a hemoglobin of 95. So, Shaima, can I ask you initially, what do you think? Because this is probably a very common type of scenario in primary care. You've got an elderly patient. She's doing really well, but she's got a lot of comorbidity, and now we've flagged up this abnormal blood. What are you thinking of doing next? Are you doing anything or?
Yeah, I mean, I think it is. I mean, she's obviously got lots of comorbidities. I mean, she's anemic, and the question is, I mean, I guess the first question would be whether she does want to investigate or not. I wouldn't be happy, really, not. I would want her to, from a kind of GP perspective, but it would really depend on what she would like to do. I don't think a fit test would be appropriate for her. And you know, would she be able to actually have a colonoscopy would be the question, really. Maybe a CT colonography.
So Julian, let me bring you in here. What are your thoughts on this? Do you want to colonoscope this lady?
I want to ask her what she feels. Her iron stores are low, ferritin, but they are in normal range. So is her anemia actually iron deficient, first and foremost? So there's a concern here that what are we dealing with blood loss? Are we dealing with bowel cancer? And then the second question to have with somebody is, what is the mortality from surgery in someone who has significant ischemic heart disease, a possible cardiomyopathy? And does the individual want to know that they may have a sinister pathology? Because if you don't do the test unless you want to know the answer, if she wants to know that she may have colon cancer because she thinks, well, if I had it, I would definitely go ahead with surgery, then you have the conversation with her and you say, okay, I'm happy with that. We can find it. We probably won't find it. We may not even have an iron deficiency anemia. But if we were to discover bowel cancer, would you want to take the risks for you of having an operation? And if the patient says to me, do you know what, I'd rather not know, I'm 87, I'm living alone, I kind of know my days are numbered, I'll take my chances and I won't do anything. But that's a conversation to have with the individual, with a very clear discussion of whether what's the kind of risk the person wants to take. It's much harder to have a conversation with someone who is I now know you have bowel cancer, I'm now going to ignore it.
So I mean, very valid points, but she turns around and says, well, you know, I've just had my hip replaced.
Yeah.
And if you think I've got a cancer, I really want to know about it because I want to live another 10 years.
Then I'd have a look.
But John, what of those tests, what would you go for?
I mean, I think the issue here is not when we were talking before about finding small lesions and prevention. I don't think that's the case here. What you really want to know is, does this lady have a significant lesion? I think she's also had a difficult colonoscopy in the past. And in terms of her comorbidities, there is a higher risk here in doing a procedure. So I would do probably a CT pneumocolon, a CT colonography in this lady, which is a much safer investigation here.
And I think the worry here is a right-sided cancer because of the anemia. Stuart, are you worried about that EGFR? Are you still happy to do a CT pneumocolon?
Yeah, very much so.
Colonography.
Yeah, so the CT colonography, it's very well tolerated. We don't give any painkillers or sedation, so there's no cardiovascular risk with it. We're a lot more gentle with the bowel preparation these days. We don't give the full purgation. We give a tagging agent which helps clear the bowel but allows us to see the colon. Patients where we can scan them on their sides rather than their front. Some people can't lie on their front. So CT colonography is a very good test for the older, frail patient. And as Mr. Warren sort of alluded to, you're looking for symptomatic, by the time they've got symptoms, you're looking for larger lesions. And we're excellent at finding cancers. We'll find the large polyps and we'll also reassure her if the CTC is negative. So, and in terms of the question about renal function, we don't have to give any IV contrast. We can do this scan without any IV contrast if that was so needed. So I think she'd be very suitable for CT colonography if she wanted investigation.
And she did indeed go for a CT colonography, which showed severe diverticular disease, which would have made the colonoscopy really very difficult. But of course, you're so good at finding polyps these days, Stuart, that there was a 10 millimeter minimally elevated polyp in the ascending and a 7 millimeter minimally elevated polyp in the hepatic. No mass lesion, no lymphadenopathy, everything else was fine. John, would you consider taking these polyps out?
I would be very unkeen to take them out. I think the risk of these causing this lady any significant harm in the future are very, very small. It's not zero, but it's very small. And I think the risk of doing a colonoscopy in a lady with difficult diverticular and with ischemic heart disease is higher. So I would be tempted to leave them alone.
Julian, would you just discharge her at that point, or would the GP's anxious that she's got a lesion and the family are concerned there could be cancer down the line? Would you go in and take them out, or would you? I
would ignore these entirely, but I also would come back to her anemia and say, is her anemia iron deficient? Actually, does she need to see a hematologist rather than a gastroenterologist? So could she have an underlying myelodysplasia? Because that will impact on her quality of life if her hemoglobin is drifting down over time. But these are definitely not the cause of her anemia or her symptoms, and there's a significant risk to removing something which is highly unlikely to impact her lifespan.
Yeah, and that was the discussion that was had, and she was very happy not to have any intervention, but she was keen actually to have follow-up with another CT pneumocolon potentially 18 months down the line. Just Stuart, if a patient is really against colonoscopy and wants to have CT, what's the radiation risk if patients, I mean, obviously if it's an 87-year-old, it's not relevant, but let's say a patient in their 50s wants to have CT, is there a cumulative radiation risk from having multiple scans?
So these days, looking at the colon in the young patient, we tailor the protocol so that there is low dose. We deliberately change the parameters. We often won't give IV contrast because we're not particularly interested in looking outside the bowel in the young patient. So it's probably the same as flying over to the States. The radiation you get in a transatlantic flight. So I personally would not. I would have a CT very happily. I think if you're following the patient a lot of the time, maybe every 2 years, and just keep an eye on it. I wouldn't have a 50-year-old having a CT for the rest of their life every 2 years. I think you'd have to be a bit more sensible than that.
Yeah, I just wanted to politely offer a possible counter suggestion, which is that I personally would have considered a fit test in that lady, because I think that in someone that frail with that many comorbidities, a fit of under 6 would be a very reassuring test, and it would allow us to then focus on the other possible causes of anemia, if we think it's an anemia that Julian has alluded to. Fit is very sensitive and specific, and is a very useful negative test, I increasingly feel, based on the publications of the last sort of 12 to 18 months. So that is something I would have considered.
You've still got the slight problem of she's on anticoagulation and it's likely to be weakly positive, come what may, and what do you do then? But
if it is weakly positive, then you can address it with the other things. But if you get a test of under 10 in a patient like that, you can tell her that she's got around about a 5 in 1,000 risk of having a size significant polyp or a cancer. And that's pretty reassuring when you're 87.
And it's a safe thing and an easy thing to do.
Yeah.
I think the other consideration about surgery as well is not really just the mortality rate and surviving the surgery. For older people, the impact of the surgery, the potential to have a stoma, which can change their life, their ability to live on their own, it can mark the transition from living independently to living in a nursing home, and that's a conversation you've got to have, frankly, with them.
I think we've had a good sort of journey along the colorectal cancer pathway. Let's take some questions now. Julian, you've been looking at the chat. Has anything come through on the chat? I can't see it on my screen. We have got some questions which were put forward prior to the meeting, which we can go through. But is there anything from the current audience?
One of the questions was, I think the exercise, so Shaima, on your slide, does exercise increase the risk? I think actually exercise and weight loss reduces the risk.
Yeah.
So it's a reduction, not an increase. One of the questions was about the how often, if someone has polyps, should they have a surveillance procedure? So I think that this is largely driven by the US polyp follow-up study. Sydney Winnower started this 20, 30 years ago. And originally it was 3 years was the follow-up. And in fact, I think for the majority of the polyps that we find, which are small polyps, we can safely extend that interval to 5 years. But you would hope that on most of the reports that you get back, the endoscopist has made that decision with the recommendation of the follow-up period on the report. And certainly for all of the Welbeck reports you should have a recommendation at the end of the report. And then if anything changes based on the histology, then there should be a follow-up letter with the histology to change the recommendation. For a lot of people with larger polyps, the endoscopist again will say, I think, you saw Brian showed you the initial patient with a large sessile serrated polyp. I think a lot of us would think that's a large polyp, which is, we want to be sure that the base is clear. We may bring them back in 6 months or a year to check that base. But those are predominantly, that will be very in the forefront of the endoscopist's mind. So they will make that decision at the time of the procedure. The procedure that will not be in the forefront of their mind is the person who had done 5 years beforehand. And they'll be coming through to you in the practice saying, when am I due my next procedure? And the two questions are, if you've got low risk and you've had, and I'll ask both Brian and John this question, let's say you're late 50s and you've had a colonoscopy which is normal, do you think you need another procedure?
So I think you do need another procedure, because most of us are planning on living a good long time. And obviously it depends a little bit on other risk factors such as family history, but if you have no additional risk factors, there's fairly good evidence that level of protection from a negative colonoscopy will last 10 years. But I'd want another one in 10 years' time.
John?
Yeah, I entirely agree with that. I mean, I think, yeah, definitely. I mean, I think this is about prevention. So, you know, you have a colonoscopy at 50. Yes, it protects you for 10. It may even protect you for longer. There's some Chinese data that would say longer, but then you get your cancer at 65. So I think you have another one, and at 60, and remove the polyps. It's about prevention.
Okay.
Can I ask then, is it 2 yearly fit tests or is it yearly?
Within the bowel cancer screening program, it's biannual. It's every 2nd year. That's the NHS program. But of course, what we're talking about is opportunistic screening. So it would not be unreasonable if at primary care level, if you're having an annual follow-up, to do that on a yearly basis. I don't know.
And US data is annual, isn't it? So their
Yeah.
data is annual.
Yeah.
The American data is annual, yes. The American recommendations.
So
I think one of the other questions that was asked by one of the GPs who wasn't able to attend was whether we would screen people with inflammatory bowel disease more often with colonoscopy, as they're more likely to have a positive fit test.
So it's interestingly, within the NHS bowel cancer screening program, we pick up a lot of patients who are FIT positive, and they don't have cancer, but they do have low-grade occult inflammatory bowel disease. So it's not an uncommon first presentation of low-grade colitis. The patient comes through the bowel cancer screening pathway, and they've always had slightly frequent bowels, and they actually have inflammatory bowel disease. So we pick up inflammatory bowel disease in that way. If you have an established diagnosis of inflammatory bowel disease, then there are very clear recommendations for colonoscopy screening. Once you're beyond 8 years of extensive disease. So if you've had ulcerative colitis for more than 8 years, you should be on a screening program. And that would involve colonoscopy, anything from every 5 years to every 3 years, or even every year, depending upon the individual colonoscopy, your latest colonoscopy, and the appearances at that point, whether there's active inflammation, whether there are higher risk factors such as strictures or post-inflammatory polyps. So that if you have long-standing extensive ulcerative colitis, you should be on a colonoscopy surveillance program.
But with Crohn's, it's reduced. Is that right? Depends on the extent.
With Crohn's colitis, it's exactly the same as for UC. But if you have small bowel or patchy Crohn's disease, not a pan or an extensive colitic Crohn's disease, then you're not considered as higher risk for cancer, and you're not then put on screening. But generally, most patients with inflammatory bowel disease will be scoped because of flare of disease, or because of concern about response to medication. So colonoscopy is used quite frequently, even in patients without extensive Crohn's colitis.
And it's important to remember that all the screening modalities we've discussed are not really appropriate for individuals with high-risk conditions. So someone with inflammatory bowel disease really should not be participating in the bowel cancer screening program. It should be under the care of a gastroenterologist, who would then be surveying them at the appropriate interval.
One of the other questions was about the role of tumour markers in screening.
Yeah, I think that's a very good question. Sarah, do you want to take that one?
Yeah, I think that's really important. I think tumour markers are, well, there's two things to say about them. One, not all bowel cancers secrete CEA, which is the tumour marker we most commonly use. So you can be misled by a false negative. And secondly, the role of tumour markers is really for surveillance after cancer surgery in people who are known to secrete CEA. So I don't think they're useful in diagnosis.
And just for whilst we're on that, a slightly elevated CEA, it does from time to time and cause a lot of confusion. Would you do a colonoscopy if somebody comes to you and they've had a slightly elevated CEA?
I'd probably, so it can go up slightly in smokers. It depends whether they were symptomatic, and probably what I'd do if they were completely asymptomatic and had no other high risk factors is simply repeat it for the time interval.
Yeah.
Can I say that the conversation I have with people around this is the difference between individual screening for people who are symptomatic and different with population screening. So I say if you're a football fan and you're at Stamford Bridge and you're watching a player on the pitch who's got Hazard on his back, it is indeed Eden Hazard. But if you're in the stands, the bloke in front of you with Hazard on his back is not Eden Hazard. And if you're in Westfield, the bloke in front of you on the lift going up in Westfield is definitely not Eden. And that's CEA screening. That's the tumor problem with tumor markers, is because you're not doing someone who has symptoms. You're not on the pitch. You're in Westfield. And that's where you have so many false positives.
Not that you're a Chelsea fan, by any chance.
I could have done it for Arsenal, but I chose not to. I didn't want to put the people through the pain of being a Gooner.
Okay, let's quickly just cover these remaining questions.
I think a lot of the questions, Brian, have already been answered.
Have we mentioned the appendicitis here? Interesting.
I think the appendicitis one is interesting because there's not particularly high risk of cancer in patients who have appendicitis, but I think there's probably that perception because if people present over 50 as an emergency with appendicitis and we take their appendix out on an emergency list, we usually suggest that they have a colonoscopy to make sure that there's not a polyp or a malignant lesion, including the lumen of the appendix.
There's two other questions here from Maria Zalazar. Patients with IBS and constipation, are there increased risk of CRC or any other GI serious condition? Oliver, I would say no.
Yeah, I would say no too, but what I would say is that those patients are even harder to spot some of the more sinister pathologies in because they have had a lifetime of those sorts of histories. And so in some ways, I have an even lower threshold for any sort of investigation because I'm so frightened.
Let's say very sort of swiftly on to the next question, which was, would you do a screening colonoscopy on a 78-year-old with irritable bowel, from Janet and McKay? And I would say that, again, I think it's a very uncomfortable diagnosis to make in a 78-year-old. That actually, are we really convinced that their diagnosis is irritable bowel? If it's lifelong, maybe. But there's the problem with someone who has symptoms that maybe would be attributed to that. And we come back to the younger adult who's had 4 or 5 different interactions with a doctor before they get to their diagnostic test because they've been assumed to be IBS, but they haven't had colorectal cancer excluded. So if this 78-year-old has had lifetime symptoms is one matter, but I think I would be suspicious of a diagnosis of IBS in a 78-year-old full stop.
I think anybody over the age of 50 with bowel symptoms, if they haven't had a pan-colonic investigation, I'd be very, very cautious about that. And use it as opportunity, as an excuse for opportunistic screening. Effectively, they could well have IBS, but they could also have an early cancer, and because it's such a common condition, so or a big polyp. So I think it is important to exclude that. What they don't need is repeated normal colonoscopies. They only need one, provided it's done in a high quality way.
Can I just come in, Brian? Just, I think John made the point that you need to have a test. It's about prevention, and if people are finding their patients are quite reluctant to go for colonoscopy, for, as you said, at Welbeck, it's a very easy procedure and by very experienced people. But some patients do not want to go through colonoscopy for whatever reason. Then CT colonography is a good line for them. It's a very sensitive test for the most important lesions, and it's better than having nothing, definitely. So I think if a patient wants to have an examination which is not a colonoscopy, CTC is a good choice.
And Stuart, this is something that we do when we consult with patients. We take all of this, we give them the options, and we take all of these concerns in. And at the end of the day, when it comes to screening and prevention, the best test is, of course, the one that gets done. And you don't want to cut across somebody's, concerns just to go for colonoscopy when they'd be perfectly happy with a CT pneumocolon, which might pick up their problem. So, and I think that's where knowing your patient and primary care know their patients extremely well and can discuss those different pathways for men or women. Shaima, what do you think? Should we distinguish? I mean, there is a slightly increased risk of colon cancer in men.
I wouldn't think so. I don't think it's that much of an increased risk. I think again, it's just, I think it's again down to family history, etc. You're then doing a bespoke change in the kind of screening process, but that would just be down to an individual as opposed to a definite kind of gender screening difference.
John, do you think there's any indication for difference?
No, I don't think so. I mean, I think that yes, there is a slight increase in men, but it's still a common disease in women.
Good. And it saves an awful lot of political correctness, doesn't it? By just saying that the same. We always get into trouble when we try and differentiate for small reasons like that. Well, okay, so we'll sign off. We'll just say thank you so much for attending this webinar. Hopefully, you've gained some useful information from it. I know we're all here to see your patients, and we look forward to continuing to see them into the future. And thank you for your attendance. Please do give us any feedback and tell us what else you would like to hear about, what topics, what subjects. Welbeck Digestive Health, we are multifaceted. We're not just all about colorectal cancer. There are other subjects. So if you have any burning desires for webinars on IBS or pancreatic disease or upper GI disease, and please, or liver disease, please let us know and we'll take that on board. So from the team here at Welbeck, we'll say good night and thank you very much.